chair is running a couple minutes late, so I figured I'd get some of the preliminaries going. We're going to call this meeting to order. We'll start off with Pledge of Allegiance. Please join me in the pledge. Ready, begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you, Madam Clerk. Could we do roll call?
Good morning, Chair Karen Spiegel. She has not arrived yet. Vice Chair Kurt Hagman.
Here.
Supervisor Gutierrez.
Here.
Supervisor Rao.
Here.
Member Anderson.
Here.
Member Williams.
Here.
Thank you. And Member Zorn. Thank you.
Thank you very much. Any changes to the agenda?
No, sir.
Any public comments on matters of the agenda?
No, sir.
Any conflicts or disclosure conflicts? Seeing none. Perfect timing. We just got through all the admin. You know how the traffic gets sometimes. I don't know who sits here because I'd adjust mine too.
I really did sneak in, didn't I?
We're in item number 7, reappointment of Andrew.
Okay, I do apologize. We are now considering the reappointment of Mr. Andrew Williams as the Joint County Public Member for his term to go through April 14th, 2023 to April 13th, 2025.
I will move, Madam Chair.
Second.
Well, that was pretty
Drew,
fast.
thank you for your service to us. Continued service to us.
That's not a long enough term, though.
Well, thank you, Andrew. I didn't realize it was time. So with that, all those in favor, signify by saying aye.
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 Any opposed? Okay, motion passes.
I'll move the minutes, Madam Chair,
Okay.
and the consent calendar.
Okay, we have the minutes and the consent calendar. That's items 1 through 24.
Yep.
Second?
Okay, all those in favor, signify by saying aye.
Aye.
Any opposed? Okay, we are now going to item 25. And this is creation of an ad hoc committee to review the executive compensation of the chief executive officer and make recommendations to the governing board. This was brought to me, brought attention to me by Eileen, and we had many conversations over a period trying to figure out which direction to go. I do want to make it very clear, it has nothing to do with Jared whatsoever. I'll be honest that if anybody caught the Orange County plan that had some issues, we chose to make sure that we are out ahead of it. So I just want to be real transparent as to what the focus was, and the reason had nothing to do with our agency. We've always been tenfold above everybody else. But just in case, we thought it doesn't hurt to do this. So it's basically just comparing the pay scale, make sure we're on market with the comparable plans in California and like. So we'd like to create an ad hoc committee and to review this, and then make recommendations to this board. And this will provide the work to work with the IEHP staff to review information that they will, and data related to other health plan executives nationwide. So we're going to look beyond just to make sure we are just doing everything so above board and so transparent that there won't be any question whatsoever. We never want to read about ourselves in the paper, particularly if it's negative. So anyway, the ad hoc committee, in discussing with Anna, our illustrious attorney, to keep us out of trouble, we decided to have no more than 3 members. And I always say it has to be an odd number, because if 2 don't agree, someone's got to break that. And my personal recommendation would be representation from both counties and then one from the remainder of the board. And then probably spend a good, maybe 2 months or so is what we talked about.
Back, but it could absolutely be earlier at the board's discretion or at the ad hoc committee's determination.
Okay. So this next step was to find, first off, if anybody is interested. I know that Eileen was shared that she'd be interested.
I'd be happy to serve in that way.
And,
I nominate Kurt.
and as chair, I would like to be the third person, if you don't mind. Plus, I've been here long. Plus, I how tired, Jared. We got to keep him. Okay, with that, we have the three, Mr. Kurt, Miss Eileen, and myself. And we have a motion and a second, right?
Second.
Okay, good. That's good that two members not on the ad hoc made the motion.
Perfect.
Okay, all those in favor, signify by saying aye.
Aye.
Any opposed? Okay, hearing none, the motion is passed. Okay. We may just get together today after the meeting. We're having pictures after, right? And then we can maybe, after closed session, have a quick touch of bases, Kurt and Eileen, just to get it apart. Can these be done through Zoom?
Subcommittee.
It's an
There's
ad
no-
hoc. It's
Yes,
not-
you can, absolutely.
Okay,
We're not government.
correct. That's why we have ad hoc committees. It's a formal subcommittee, we have to have a Brown Act. I've learned after all these years. Okay, we are now on item 26, and we have the Chief Executive Officer update.
Thanks so much, Chair Spiegel and members of the board. Sure hope that you folks had a great weekend, got to relax a little bit and enjoy the beautiful weather as well. You know, I thought it would be great to share a little bit of what we're calling within our organization a mission moment. And we have these moments prior to all of our leadership meetings where we share with our leaders as well as with our all-employee team meetings just a short, quick story about something unique that's happening within the organization or externally. And I thought I would just share with you a really remarkable story of one of our employee team members named Dennis Caney. Dennis actually was just a phenomenal guy, absolutely super, super cool guy. He actually was one of those folks that every time I saw him in the hallways rolling around in his electronic wheelchair, had just an incredible smile on his face, was so upbeat, and was truly a cheerleader for IHP. Just last month, he passed away, and we lost Dennis. And it was an interesting story because he was such an incredible person that he loved to do all kinds of fun things. And it was in 1992 that he actually broke his neck from an off-road solo motorcycle accident, became a quadriplegic, and still continued, though, in his calling to serve the community. And it's just fascinating to me that after that accident that he had, it was in 2005, that Dennis was actually hired here at IHP to be the very first social worker. He was our very first social worker that was hired. And he's quoted that getting this job at IHP was the biggest blessing on my life. And I share this with you, and I'm going to pass around to you his Celebration of Life pamphlet that was put together, because he was so insistent with his family that actually inside of the Celebration of Life pamphlet, you can see there's actually that quote down at the bottom right about IHP. and the impact that IHP made, that getting this job at IHP was the biggest blessing on my life. And his family actually has a special thanks to the IHP team, both inside the order there of service, and they also just made a very, very unique gift that they wanted to make sure that IHP had. And it's some wooden tongs, actually, that says, "Giving is receiving." That was a quote that he said. And on the other side, it says, "It is a good feeling when you can help someone." And I'll pass this around so that you folks can see that. And I just thought it would be so important to just take a moment to acknowledge folks like Dennis. You know, we have, of course, hundreds and thousands of touch points with our members and providers every day. The team here at IHP that does this work, whether they're in a wheelchair like Dennis and they happen to have had a life event that created a quadriplegic situation, or whether they're someone that is running around all over the community to make sure that things are well taken care of. It's incredible the impact that folks have, regardless of their mobility, regardless of what past might have had to them. But I would argue that Dennis could actually connect with our members like nobody else because of what he did go through and because of the challenges that he did have. And so I just thought it would be good to share that quick story with you about one of our very own who made such an impact on this community. And we'll be sharing throughout the year just some mission moments along the way for both team members as well as providers and community members. And I just thought this would be a great way to just start the meeting off, to just say thanks to Dennis and his family. So with that, we'll jump into our, of course, monthly membership report. And there's no, of course, as you folks know, there's no stranger to these numbers. They keep on heading north on us with the public health emergency actually just now coming into effect this month. We actually thought it would be really, really insightful for you folks to understand a little bit about how that public health emergency unwinding is going to impact the numbers and some of the unique connections that we have with our two county partners that will help to make sure that the numbers that you see on the screen will be as stable as possible over the 12-month period that really starts with the first disenrollments in July, although those letters and the packets are starting to go out now across all of California, across our entire state. And I really wanted to just say a big thank you to Thomas Pham and his whole team that has done some incredible work in conjunction with a host of other folks. Our whole exec team and leadership team have all been engaged in this process. And I've asked Thomas to share a couple of slides in partnership with our two counties because we're very unique in the state of California to have the kind of partnership that we do with our two counties, an incredible partnership that has been fostered out of an immense amount of data sharing, a lot of trust building, and making sure that we're doing the right thing for our members and, of course, the community. So, Thomas, I know that you're going to come up and just share a little bit more detail about the redetermination process. As I was sharing, I think prior, and I know I've shared this with our leadership team, I was talking with some of the who are considered the grandparents of the Medi-Cal plan, the Medi-Cal managed care plan in the state of California. All of them independently have said, Jared, this is one of, if not the most single important thing that plans should be focused on for this year. This is a huge, huge change in the way things will be happening because of the last 3 years. And I really appreciate Thomas and his team, along with our entire executive team, who's really been focused on this as well. So Thomas, thanks for sharing some detailed information on this.
Thank you, Jared. Good morning, board chair. Good morning, board member. Thomas Pham, VP Strategy. So part of this presentation is my honor to invite a couple guests to our board meeting today, and actually they are your superstar in the county. So first, I would like to invite Mr. Gilbert Ramos and James Lakota. Mr. Gilbert Ramos is the director of Seminole County Department of Transitional Assistance Department, and James is the assistant director of the Seminole County Department Transitional Assistance Department. And then would like to invite Laura Fuller. Laura comes from, she is the Deputy Director at Riverside Department of Public Service. So all three of us will co-present today to the board about Medi-Cal redetermination. So first of all, I would like to share how IHB prepare for the Medi-Cal redetermination. As you all know, that the continuous Medi-Cal coverage required by the public health emergency ended March 31st. So April 12th, actually in a couple of days, that the county will start mailing out the Medi-Cal redetermination packet to all the IHB member who have the renewal date due June 30th, 2023. So our member, we have more than 60 days to review the packet and return to the county. And how IHB prepare for this significant event. So first of all, of course, the first strategy is that we partner very closely with our county. Without the strategic partnership, we wouldn't be able to get the data exchange, because data exchange is so important that every month the county share with us whose IHB member will have to go through the renewal process. We're the only one in the state at this point that have that data. So thank you to our partners, Seminole County and Riverside County. And we also align on the strategy and the messaging to ensure that our member get consistent message from IHB and the county as well. Second strategy that we have, we hired the new eligibility team, leading by Shalon Jones. Shalon? So Shalon Jones is our Director of Member Eligibility, that leading the eligibility team, who will provide hands-on application assistance to our member. So when we get the list from the county, the team will do outbound call to all of those members and help them, walk them through the application process. And of course, our third strategy is we focus on strategic communication, the targeting member, provider, community. So because of the data exchange with the county, that we're able to send targeted messages to those members. Because not all members have to go through the renewal process. About 30% of them auto-enroll, and 70% will have to go through the manual renewal process. So it's very important that we send the right message to the right member. And so thank you to marketing, provider communication, and the community health team that partner with us in the strategic communication that send the message out to the community. Third, that we do a lot of presentation to our provider network, that including our provider advisory committee, the IPA, the PCP, and the hospital. We will have 2 training sections for the hospital on the 18th and the 22nd, I think. And Supervisor Gutierrez, thank you for having David, reaching out to us, and we are partnered with David to join your Medi-Cal redetermination telephone town hall on the 18th. So we'd be very honored and excited to join the town hall, telephone town hall with you. And we do a lot of change awareness campaign that include op-ed article, Jared write an op-ed article in the big publication. And we do press release, have brochure, flyer at the community event. So with that, any question on the IHB readiness plan?
Just to clarify, what is, I would say criteria, what would have the trigger for a redetermination that would not pass through? You said 70% just pass through, but 30% have to go through. Did I get it backwards?
So the other way around, 30% will automatically enroll. And with that, our county partner will be well explain that to you. The 70% will actually receive a print Medi-Cal redetermination packet. So good question that I will transition to our county friend to explain that process to you.
Morning, Madam Chair, members of the board. James Licurdo, Assistant Director with the Transitional Assistance Department. Super excited to be here. Ooh, talk a little too close to that thing. I'm thrilled to be here. Happy Monday again. This is an exciting day for us. We get to come and talk about the important things that we were doing to help prepare customers for the upcoming Medi-Cal renewal. And let me pause for a second as well and just highlight one of the items that Jared had mentioned. It's a strong partnership that San Bernardino and Riverside County has with IHP. This is not our first time that we partnered. I will age myself a little bit, but I won't age Thomas. I've been with the county now for 27 years, and of those 27 years, I've been fortunate enough to work with Thomas for many, many years. So first, let me go ahead and I'll tackle your question about the 30% that actually go through, they're successful through the automated process. So through our project, 60 days in advance of the Medi-Cal renewal, they bounce it off the federal hub. Once they send it over to the federal hub, they're looking at tax household information, they're looking at income thresholds. If they're successful, then it comes back and they don't have to go through the Medi-Cal renewal process. So that's where you get the 30% that will automatically go through the Medi-Cal renewal process. Hopefully that makes sense.
Will they be notified rather quickly? So let's say at the town hall meeting or we do any kind of a reach out, do the members already know by this point whether they went through or they're having to go through redetermination?
Yeah, thank you for that question. So a member will receive a notice of action letting them know that their Medi-Cal renewal was updated one more year. So they will get a notice of action through the mail.
Okay.
Thank you for that.
Anybody else have a
Yeah,
question?
I do, Madam Chair. Oops. Just real briefly.
Yes, sir.
Mechanics. People get a lot of things in the mail. Do we have a call center, or can we maybe do that part of it? I want to make sure that people understand, because there's a lot of things coming in the mail all the time that are confusing, a lot of things on emails that are just
Sure.
plain spam, or I want to make sure they have a personal touch in that process somehow. Is that possible?
Great question, Supervisor Hagman. Appreciate that. So it's actually on my second slide that talks a little bit about our internal efforts that's helping customers bring awareness and help them prepare for the Medi-Cal renewals. One of those items is our call center that has a message that is played to talk about the importance of updating contact information, talk about text messages as well. This is the text messaging campaign is like, you're stealing my thunder because it's so incredibly important, so powerful to be able to share information via text message, be able to tell customers that a Medi-Cal renewal is coming, that a Medi-Cal packet's been received or that we received it, that it's incomplete, that it's been processed. So text messages is one of the vehicles that we use to be able to communicate. In addition to your point, the call center, as well as Benefits Cal, that's our online portal that helps convey information to customers as well.
So, out of all the different methods, you plan to have a personal touch confirmation, basically, because we see this on other boards. We have property owners that we like moving transit through. We got to contact. It takes us like 2 years to get a hold of the real person because we can't track them down. But we did leave them 27 emails or whatever, but no one pays attention. So I'm just hoping that whatever we need to do to staff up to use whatever method, including going to their provider. If that's, like, if we have they moved, we'd have a bad address and email and phone number, but we see on our records they're seeing a particular physician, can we enlist their help to make sure we have good contact information or to reach out to them somehow?
Great point, and that's one of the, let me back up just for a quick second, because there was a program that DHCS lifted up many, many months ago, and it was reaching out to healthcare providers, reaching out to faith-based, community-based organizations to say, hey, who wants to be a DHCS ambassador? Part of that ambassadorship was getting out to the members and making sure that we're updating contact information. Our Medi-Cal universe hasn't gone through the Medi-Cal renew process now in over 3 years. So one of the critical areas was making sure that we have current contact information from address to phone number to email addresses. And then let me also pay a quick compliment to IHP, because when DHCS lifted up this program, IHP was at the forefront, raising their hand to say, what can we do to help partner with counties to make sure that we're a critical part in updating contact information?
Great. Thank you, Madam Chair.
Thank you, Madam Chair. Quick question. What is the income threshold? Because I know it updates every year.
It does.
Like, what's the current
Great question, Supervisor, and I'm sorry, I don't have that in front of me. I'd be happy to be able to grab that and share it with the board later on. I know they just increased it, but I don't have that threshold.
Because it goes based on like household.
Their
how many-
tax filing household, yes, sir.
Right, the house size. And then the other idea, and you might already have this, and I think that's great with the texting, is it possible to know, like, does IHP know who the Spanish speakers are? Because if you do, is it possible to extract that data and then maybe send text messages in Spanish to
Yes.
those folks?
Yes, sir, and I hear Thomas saying yes, and I know that IHP has a different thresholds when it comes to language, so do both Riverside and San Bernardino. So our messaging, our marketing materials is definitely targeted to those threshold languages. Yes,
Nice.
sir.
And so it's going to be Riverside and San Bernardino that are doing the campaigns, or is it IHP?
Well, it's a little bit of both.
Of both,
We
all
have,
three.
we toggled back to my other slide, we have marketing efforts from the state, DHCS.
Okay, good.
They've been a great partner. They created actually a toolbox for 58 counties that we're able to go in there and grab information, so we're not recreating marketing strategies. So they've also been doing television ads, radio ads. So we have our state partner, DHCS, and then we have our local partners here, San Bernardino and Riverside County. We have our own internal strategies, and then that's where the strong partnership with IHP comes into play, because you're also helping out the counties and doing that marketing.
Thank you, sir.
Just triggered something.
Yes, ma'am.
You have, each county has more Medi-Cal constituents than just IEHP.
Yes, ma'am.
So we only help with just the portion that's IHP. So how do you separate that and go after or reach out to those that are not part of IHP?
Great question. Thank you. So we also have Molina as the other healthcare provider, and we have Kaiser Permanente as well. So those are other partnerships that I know I can only speak for San Bernardino, but that is other partnerships that we are reaching out and creating, as Thomas indicated, data sharing MOUs. So they're able to send us information with their membership, and then we're able to share data back with them.
So it sounds like you guys are really busy.
We are. Yes, ma'am.
Any more questions? Okay.
Thank you.
Yeah, let me go ahead and introduce my good friend, Laura with Riverside County. Again, thank you so much for your time. It's a pleasure to be here.
Good morning. My name is Laura Fuller. I'm a Deputy Director for Riverside County. I've been with the county for almost 30 years, actually, so.
We
it
had a
is-
competition there, 27, 30. Riverside wins.
I guess we all can't help like how old we are or when we started, right? So there you go. But I am also, my pleasure to be here and provide you with any information we can so that you guys feel confident that we're doing everything we can for the residents of Riverside County to assist them with this process that we haven't done in over 3 years, right? So if you see on the board that we're doing a lot of the same things, I know theirs was a little more detailed, but all of our communication to our customers does go out in English and Spanish. We're doing not only posters in our lobby, but we also have lobby monitors where we'll be posting information about the REs, when they're due, where to look, where to update their information. The state did send out mass mailers to all Medi-Cal beneficiaries in California, asking them to make sure they update their information. We want to make sure that they get their packets in time, but we also did that internally in Riverside County. Our other plan is to do monthly mailers to those who are expecting to have their RE due, so they know, hey, you're going to get this packet in the mail, or you're going to get the letter stating that it's already going to auto-renew. We're also working a lot with our community-based organizations, our clinics, our UHS clinics, our UHS, a lot of our, we have and I don't know how much you know this, but we have a community outreach branch, and they visit clinics, they go to farmers markets and other things as they're asked to come out into the community. They're going to also be providing information during those visits that they do. We're going to have increased lobby staff in our lobbies to assist with answering questions, providing information, helping people with their reinvestigation packets if they should need that help. We also are utilizing robocalling and text messaging to outreach to our customers whose RE packets are going to be due every month. So we're trying to do that, just as much information as we can. We're also instituting an option on our phone system where they can press a button to get information, and then if they still have more questions, they'll automatically be put in touch with one of our offices to get their questions answered or provide whatever help they need. So,
if a household doesn't respond, and the renewal doesn't go through, how long does it take to get back in with Medi-Cal?
So with Medi-Cal in particular, we're obligated to reinstate them if they provide the information within 60 days of when they do turn the paperwork in. And so we always want to try to do everything with Medi-Cal within 45 days. That's what is regulatorily mandated, but we always try to do it as soon as possible.
But let's say it's September, October, and they hadn't been to the doctor since, so they want to go to the doctor and find out that they are no longer enrolled. How long will that process go?
So it's kind of, so with Medi-Cal, normally, I mean, there's not necessarily what they can always go to the hospital, the emergency room. And that's normally, I don't want to like not say it's not important to put them back on, but we would still try and do it within the 45 days. If there's an emergency, we do try to do it more quickly. And if they have everything we need and there's no problem, it's usually done probably within a week.
But we shouldn't tell everybody that.
No, because you never, I mean, you never know what's going to happen with a certain household or what they have or what they have to bring back to us so that we can determine eligibility, yes. But, we always tell them that we try to do it as quickly as possible. And if there is an emergency, we do try to take care of those right away.
Any additional questions, anybody? Sorry, we're asking so many questions. This is really.
No, it's perfectly fine, and I know Mr. Gutierrez, one of our program specialists, will be at your town hall, so that will be very beneficial to helping with those questions and that type of thing, so.
Okay.
Thank you.
Thank you so much. I thought this would be important to just make sure you folks were in the know on this, because this is a big deal. And literally, any ideas that you might have, if your teams have ideas, shoot them our way. Every now and then, I know even our executive team members and directors, you'll hear ideas that will come up. Keenan will pop down and talk to Thomas and say, hey, I've got an idea for you, or Susie will share something. And the goal here is to literally use every single method that we possibly can think of, whether that's the hospital registration clerk, whether that's at the provider office, that front registration clerk at doctor's offices. I even just this morning sent an email and said maybe we should hire skywriters. I don't know. But just everything we possibly can do to get the folks' attention, because part of the problem with this and the nuance is that for some people, they've been receiving eligibility packets, but they've been told to ignore them. You don't have to worry about it because it's the PHE, so don't even worry about it. So to get them shifted now out of that mindset of ignoring for 3 years and now getting them engaged, big kudos to our county partners, and even Thomas's team has actually created their own call center where when they get the list from our 2 county partners, they're actually going by the month of eligibility that's coming up first, and they're making outbound personal calls to those lists to really get them engaged starting as quick as possible. So some great work happening, but we are totally open. If you folks have a brilliant idea in the middle of the night, text me anytime. Give us some thoughts
Careful
or
what you
ideas.
ask for.
Anytime. This is important.
I do have a question. Do we work with the schools at all on this?
Thomas, do you want to talk about the school, the work that we've done or have done with the schools on Medi-Cal?
So we partner with the community health department, that the community department send out the toolkit that the EHCS create for all, health plan and all community partner to you. So the community health department frequently send out the toolkit that the EHCS provides to the school and the other organization in the community as well.
When One other thing that just recently came up, I saw an article in Becker's, that newsletter that they send out on a regular basis about best practices related to this and what various different organizations were doing. But when I compared their list, Thomas, to your material, I think you've got it all covered and then so much more. They were stressing the same thing you did, which is the collaboration between county organizations. That was the way to try to ensure the fact that we had overlap and would be able to access and support the majority of people. But that was just an article that came out probably about 2 or 3 weeks ago.
Yeah, and we should note, Board Member Zorn, that Thomas and our 2 county partners were actually highlighted by DHCS as a best practice for the state recently, and so huge thanks to Riverside and San Bernardino counties, along with the IHP team for that. It's great work that they're doing, so really appreciate all of you. Thank you so much for that work. Well, moving on, out of redetermination land, I thought we would just share with you briefly a little bit of what's happening on some of our innovation work with Dr. Ed John. This is kind of a small slice of his Chief Quality Officer role, but it's an important one, and that'll be good for him to share just a quick update with you. Ed?
Yes, good morning, members of the board. One of the things that we're doing here within our quality department is trying to figure out ways to really accelerate and move the needle for quality improvement in our actual performance of some of these harder to move measures. And one of the ways that we're thinking about that is actually looking for ways to partner with out-of-the-box sort of creative opportunities to kind of help us kind of think beyond what we know today. So today we're really good at knowing what we know, but we're also not really good at knowing what we don't know. And one of the goals of hosting an innovation design challenge specifically focused on some of our quality HEDIS measures that are harder to move is so that we can get a more holistic approach to make sure that we're doing everything we can. One of the things that we're hoping to do for this design challenge for the first get-go is to work on a specific handful of measures and inviting companies, whether they're focused on care coordination, focused on data, focused on actual I guess, interventions that we as a health plan can operationalize but have not yet thought of, but to kind of see that variety of ideas out there and then to collectively, I guess you could say in a Shark Tank format, assess whether or not we'd like to proceed with these types of outside-of-the-box solutions. And one of the things that we're excited about with these challenges is that not only would it encourage innovation within sort of a health plan and sort of encourage a different way of thinking, but also allow us to see how others are thinking, again, access to a talent pool that we may not have had access to prior, and also figuring out how we can sort of promote more contextual problem solving. Again, this is not innovation for the sake of innovation, but for us to kind of move ahead based on the context of the environment that we're facing today. So more details to come, but as we roll this out, we're hoping to have this first design challenge sometime in the summer. And again, as we get closer to that, happy to provide updates.
Thanks so much, Ed. Sure appreciate that. We're really excited about the potential of just learning some new things there, so it'd be a lot of fun too. Up next, wanted to just share with you our provider dinner series continues. Thank you so much, Supervisor Spiegel, for joining us there out in the low desert for the most recent one in March. Had a great time there with providers and really always love to get their feedback every time. And we just learn so much at these dinners on what's really happening out in the field. Now, I'm sorry that we didn't have the dates on there for the next ones, but I do have the dates for you. April 18 is down in Menifee. So if you'd like to join us in Menifee, you're welcome to on April 18. And then May 25 is Temecula. So if you'd like to join us in Temecula on May 25, we'd love to have you join us there. Up next, I wanted to say a big shout out to Michelle Finney and her team out at Desert Regional Medical Center. They received their level 1 trauma designation. This is huge for the community there, just to be able to add another layer of protection for our members and for the community there in the low desert. So a big kudos to Michelle and her team. And then also on the next slide, a big shout out to the RCH team, the Riverside Community Hospital team, for receiving their major organ transplant certification. Jackie and Fred and that whole group there that oversees that hospital. We're just thrilled that, again, this adds additional access points to keep folks local instead of having to send them over to the west for any kind of transplants for this in particular, kidney and pancreas and, of course, liver as well. I also wanted to share with you, just had the opportunity to go back east and share at Becker's. Board Member Zorn, I'm just going to turn you into Supervisor Zorn, sorry. Board Member Zorn, you had just mentioned Becker's. Becker's Healthcare is just an incredible everyday publication that comes out that if you'd ever like to sign up for it, it's free. You can actually sign up and get all kinds of details and information about what's happening in healthcare today. It's very, very timely. And they have an annual conference that takes place every year in Chicago, and it was just an honor to be asked to speak back there and be on a panel with some other folks there in the industry. The topic was the top issues for health plan executives in the next 12 months, and we had a lot of fun with that. Shared all kinds of fun stuff and learned a lot too. It was really good to learn a tremendous amount as well. So huge thanks to the team for all the work they did to prepare me for that. I've got such a great group of people that helped me pull all of that together. So big thanks to that team. And then rounded out, we thought it'd be just great to give a little shout out to our supervisors from Riverside County. Huge thanks to the work that they're doing there on a recent event that our team happened to be there with you to see. And so thank you so much for the work that you folks are doing there with taking a stand against child abuse and the work that's happening there. So many, many thanks. And also wanted to say thanks finally to Supervisor Rao and her team for really assisting us in connecting with the Crestline issue that was happening, that major emergency that was going on up there. Claire in her office, Danielle, that whole team really helped to pull us together and give us direction on who in the county we should be partnering with for our community health teams to get out to. And I really appreciate your help, Supervisor Rao, to just be able to connect our people with the right people there at the county. So thank you for that. We have a very quick video we thought we would show you of that because there's some incredible impact that took place up there, and thought we would just briefly share that with you.
It'll be another moment.
Okay.
I'm looking at them, apologies.
So we brought a food drive. Over here we're helping the communities. Unfortunately, their grocery store has collapsed, and we're just trying to help them out, bringing them some fresh food, and making sure that they are able to go through this terrible time, and just making sure that they're able to at least have some fresh food for their families and feed themselves. So the important thing, honestly, is that IEHP is present and we're helping. That's literally what we're about, helping our members, making sure that they're obviously the center of our universe. And even if we're able to provide as little as some food to them, it's a great help and something that they don't have to worry about.
I got a message in the middle of all of it from IEHP, saying that they were there and they wanted to help. And I cried when I read that text, because it really does mean something to know that outside of a community, other people are noticing and they're sympathizing.
I appreciate you guys with the Mama. I guess it's coming out now. We were just in survival mode, trying to survive it. That's it. Thank you, IHP. Thank you from the bottom of my heart.
Just really appreciate the partnership with the county, and again, a huge thanks to Supervisor Rao's team for just helping to connect the dots for our team to be there for those folks. That concludes my CEO report, Chair Spiegel.
Is that how you prepare your documents? Oh, okay. Did you want to leave him in, or you? I was just teasing with him.
Oh, no, that's okay. Would you like to move to finance?
No.
No?
Yes,
She's
move to
gonna skip
finance.
Oh, okay,
But
okay.
I think you should do the pose.
He, sometimes in his office, you never know, you'll go by and see his office, and he's standing in there doing some yoga pose. But, yeah, Keenan, it's great. It's great. So we love it. It always keeps us on our toes.
Good one.
Leona, we may need to change pictures. All right. If we can go to the next page. All right, so we have the February financials. I'll go over the month to date and then the year to date, and then update the board on next month's presentations, because we're going to have a couple of presentations there. So for the month of February, we came in at about 54.9 million in positive net surplus versus a budget of 46.3 million. We had a positive variance to budget of just under 8.6 million. On a year-to-date basis for the first 2 months of 2023, we're at a positive net surplus of almost 87.4 million. The budget for year-to-date is just over 56.5 million. So we have a positive variance to budget of about 30.8 million. So as you can see from the financials there, we're a little bit ahead on revenue. Expense on a year-to-date basis is running a little bit lower than what we expected, and the same thing for the budget. Now, next month, we will be bringing our budget update. If you remember back, our revenue really wasn't finalized till about February. So we're going to have an updated number on revenue. We also have some changes to medical expense related to the non-utilizer redetermination issue, and we'll go into depth on that so you can see what we assumed in the budget. And then also, I think from the December presentation, we also had some questions about administrative expense and FTE growth. So we'll have several slides on that to walk the board through where the growth is and how that matches up with the additional Medi-Cal programs that we're being asked to do, as well as some of our strategic initiatives. Any questions on the financials?
You always have good news for us.
Good news till July.
Yeah.
Actually, I guess that's technically August. So.
Yeah.
I had just one question, whenever you're ready. I was wondering if you could do a bit of a deeper dive for us, Keenan, on the second bullet point there, the unfavorable medical cost variance compared to budget related to unbudgeted CalAIM incentive expense, et cetera. Can you just teach us a little bit more about what that represents?
Yeah, we have 4 or 5 incentive programs out there. We have the CalAIM incentive program,
Right.
That provides incentives for like technology hiring providers for both community supports and ECM. We have a student behavioral health initiative that's out there as well to support integrating behavioral health into the school districts in both counties. We also have a housing initiative that's also out there. And, you know, the way this works is we have revenue that flows down to the plan, and sometimes the timing of that revenue does not necessarily match up with the expenses that we pay out. In fact, a lot of times we're paying out in expenses to the providers to support their various CalAIM activities before we receive the revenue. And the revenue is usually tied to some sort of report that has various requirements or initiatives that we must meet. So it's almost like revenue lags, so sometimes we get out in front with the expense side.
Super helpful. Thank you.
You're welcome. Any questions?
That's it?
That's it. It'll be long next month.
Oh, I didn't read all the way through. It says 12 slides. However, Keenan may only discuss the first slide. So I was,
That's okay.
I didn't want to cut you off.
We all make mistakes.
Oh. Paybacks.
More yoga.
Just teasing.
Remember who's up here.
Needs to go to the meditation side.
That's right, that's right. Oh, boy.
Jared, we better move on real fast.
Yeah, let's do it. Let's do it. There might be a committee talking about somebody else soon, too. We've got a really great operations update for you, and I know Susie White's going to introduce this for you folks.
So I would like to introduce Sylvia Lozano, our VP of Hospital Relations, and some of the amazing work she's been doing with our hospitals. She's super shy, so here it comes.
I'm kind of nervous to be the next one up now. Good morning, members of the board. Sylvia Lozano, VP of Hospital and Ancillary Relations here at IHP. It's hard to believe that it's been 2 years and a couple weeks, hint, hint, if I get a gift for being here for 2 years. About 2 years ago, Jared approached me as well as Jania Fick on this concept of bringing HQI Cares to our hospital partners. And just to level set with everyone so that everyone understands what this work and all the partners that make it happen is HQI stands for Hospital Quality Institute. They are the arm, the quality and patient safety arm of CHA. And then also partnering with Beta, which is the largest professional liability carrier for hospitals. That partnership came together to create this framework of HQI Cares implementing Beta Heart. And so, next slide, please. So what does HEART stand for? You've seen this, it's in your packet, but really brings together all of those attributes that bring about instilling a culture of safety, creating a culture of trust, also bringing in that psychological safety within a hospital that creates that willingness to speak up when it is needed. So that is what HEART stands for. Next slide, please. These are the domains of HEART, and these are the domains that our hospital partners have gone through. And so I'll briefly touch on each one of them. One of them is the culture of safety. So we assess what that looks like within each hospital. Communication and transparency. This is where we're talking to a lot of staff to see how they feel about the communication and the transparency within an organization. We also look at rapid response incidences and making sure they have incident reporting in place. And not only do they have the incident reporting, but they're doing that level of analysis in the organization that can drive change, and also ensuring they're doing early resolution when harm events do happen within the organization. And then what are they doing for those caregivers, those second and third victims of harm when a harm event happens? Because it's not just the patient, the family, it's also those who have participated in that event. So those are the 5 domains that our hospital partners have gone through an assessment of. Next slide. So with the support of Jared, Keenan, Jania, Dr. John, we were able to bring this program to our hospital partners and embed it within our P4P. I'm not an old hospital person, been told it's vintage now, a vintage hospital person. We all know the importance of a culture of safety, but sometimes we focus a lot of our efforts in the hospital space with the margin, right? What can we financially invest? And so through this P4P incentive, we were able to offer this program. If our hospitals' incentives
within a variety of different milestones, basically dangling the carrot where we needed them to go. And so this is what happened over the last 4 quarters with our hospital partners. Not only did they sign an agreement, but they also had to do certain things by quarter to achieve the incentives. And so let's see how they did. Next slide, please. So we had 24 hospitals at this time that signed up to be part of the year one. We call them year one cohort one trailblazers. And they achieved all 8 milestones. And the only reason the other hospitals, and you'll see later in the presentation, did not sign up was because they didn't have the foundation in their organization. They didn't have potentially a quality director, a safety director. And so they didn't want to go on this journey until they had that. And there were other things like COVID that were going on that they felt that they really couldn't give this framework the attention that it needed. Next slide, please. So this is a workshop. This is the last workshop we had. Organizations are required to go to 3 workshops as a component of this program. We need them to step away from the 4 walls of a hospital. We need them to get educated. We need them to do simulations. We need them to network and learn from each other. And so this is where I always I come back very energized. All my hospitals are there. It feels like speed dating because you can talk to all of them. And so you have, physician roundtable where there's conversation about you are part of this. This is not just administration at a hospital. And then also we had Jared, who was there as an executive leader, who also spoke about the benefits for those hospitals that are thinking about embarking in this journey. So a very, very lively time, a very energetic time. I actually gave a version of this presentation to PAC last week and actually had Dr. Calvin Patel, who is a hospitalist, speak up about the benefits that it has provided him as a hospitalist within the organization. Next slide, please. These are the areas of focus that the hospitals have selected. We've actually had to rein them back and say, pick one. There have been a lot of folks that have secondary already planning going on because they're so energized about the work that is happening in this space. Next slide. This is our cohort 2, year 1. So all of the hospitals who couldn't do year 1 with us, they all signed up for cohort 2, and it's really nice to see. It's kind of like, going to college or high school where you have the new people coming on and the older ones are there and they're not doing the hazing, but they're bringing them into the fold. So it's been great to see that camaraderie amongst our hospital partners. Next slide. I think that's questions, and I do have in the appendix, because I think it was you, board members, Oren, that said, how do the hospitals feel about all of this? And so we went out and got testimonials from our hospital partners from all regions, and these are the kinds of things that they're saying. I think when I read Yvonne's, I was just at Corona Regional about a week ago, just the gratitude to IHP for what we have invested in them and in their culture. I think the other piece that is also very, very warms my heart is that when we look at everything that they have done without us even telling them, like for example, San Gorgonio has badges. They're ambassadors and they're proud of it. There's Coffee Corner where Corona Regional is sitting down at noon where people can come and talk about where is the next harm event going to happen, and that open communication. KPC Global with their 3 hospitals have revitalized and started a newsletter campaign, right? So it's just amazing. We didn't tell them to do that. It's what they're doing on their own. So
Just
any questions?
One comment on that too, Sylvia. I had a physician approach me out of the blue. I think it was in Stater Brothers or whatever, but his point was that this is out of the usual realm of communication they hear about IEHP, and it was such a gift to them because they felt like health plans are paying attention to some of the additional challenges that are going on within the healthcare delivery model. and are showing their concern by actually doing something, acting on their behalf. So it was received very, very well in
Yeah.
a super positive way.
Thank you for that. Yeah, that's the word I hear a lot. This has been a gift. Our hospitals needed a shot in the arm, a bolus of compassion, and this is what this is doing for them. And so, this is an example of how when we say our unwavering commitment to our providers, this is our hospital partners, and this is showing that unwavering commitment to them.
Yeah, appreciate it.
Okay.
Thanks, Sylvia. I'm just so excited about this program. Again, being a former hospital executive, I've just seen the power of this personally when this is implemented in an organization, and really appreciate Sylvia's work on this and the speed at which we were able to make this happen across the entirety of the network. It's just incredible how fast she was able to get this thing rolled out. So huge thanks to she and the entire team for working on that. Thank you so much. Susie, I think you've got another item that you're going to be bringing forward.
I do. So we're going to have Dan Gomez, our VP of Provider Experience, present today the 2022 Provider Satisfaction Results. I think this is Dan's first time presenting.
Definitely first time presenting, but not first time attending. Hi, I'm Dan Gomez. I'm the fairly new Vice President of Provider Experience at IHP. Just rejoined the organization in November in this role. It's probably important to note that I was originally with IHP in 1996 when we went live, one of the 2 provider relations representatives we had back then. So it gives me kind of an interesting and fun perspective coming back in this role. So we're going to present for you the 2022 Provider Satisfaction Results, and then the final slide will actually get into some pretty fun stuff on how we're going to address 2023. Next slide, please. So the survey methodology, we used a vendor, a certified vendor, to go ahead and conduct the survey itself. And the surveys were sent via email and mail summer of last year, with follow-up calls to non-responders shortly thereafter by that same vendor. The response rate of 27%, which is an improvement over prior year, significant improvement. But I think the really exciting thing was the number of surveys that actually came in compared to prior year. We had a larger sample that went out, but we had a large number of surveys come in. I think we had about 375 surveys prior year, and this year we had 1,500 surveys come in. So that gives you a better idea of actually of how we're doing. The total number of surveys, very important there. Primary care, we received 549 surveys. That's a 29% increase of respondents than prior year of 27%. Specialists, we had 284 surveys, which is a 17% response rate, about the same as prior year. And in behavioral health, we actually had a very large response rate, 674 surveys. That's 32% of those that were sent out compared to prior year, which was only 15%. That part of that probably speaks to the continued growth of the program itself and the providers and the maturity of the program itself. Next slide, please. Okay, we'll just hit on some of the composite category results. So overall satisfaction, even though there's a slight decline from 2020 to 2021, 2022, still doing extremely well, especially when compared to other health plans. But it is an area that I'm focusing in on, as we'll get to later. Finance issues, again, the response rate currently was very positive, fairly flat on UM and QM from prior year, an improvement, network and coordination of care, flat for pharmacy, and improvement on the call center staff. Provider relations, and again, another area that I'm very, very much focused in on, a steady decline from 2020, 2021, 2022. Even though it's overall and compared to other plans, it's a good place to be. It's definitely not good enough. So I'll be sharing with you a lot of things we're doing to kind of address that. And then whether or not the physicians would recommend other physicians to IHP. A very good approval rate of 98%, which is fairly consistent year to year. Next slide, please. Okay, so the key findings, top 3 drivers of overall satisfaction. So the call center, which would be the provider call center, and I guess this does include member call center as well?
I think this is mostly provider.
Mostly provider call center. So which is also under me, and this is fun because we've got a lot of folks taking calls from providers. Major driver in the survey results. Procedures for obtaining authorizations, referrals, pre-certification. And we hear a lot of this also at the PCP dinners. They're very happy with IHP in this area. And then having access to knowledgeable staff. Pharmacy and the health plan call center ranks significantly high, 99th percentile, whereas provider relations was the lowest at that 88th percentile, which I touched on earlier. So the custom composite results, we have an overall decline in performance for timely access questions. We have an overall decline in performance in interpreter services questions, and then an overall improvement in performance in telehealth questions. Okay, next slide, please. So specifically from the primary care physicians side, the highest scores we received were in the area of interpreter services. And I think you've probably had a chance to touch on or review some of these. Happy to dive into these later if you need me to. Whereas in network and coordination of care from the primary care physician's perspective was an area that they did not rate us very well in. I think a big key here is a lot of communication challenges between primary care and specialty care is something that we continue to try and find solutions for. Next slide, please. Which is fun. On the specialty provider results side, they're a bunch of happy campers. So again, interpreter services, a very high satisfaction rate with interpreter services, whereas low rates with specific to pharmacy. So that's everything from basically the types of meds that are available and the mainly the types of meds available. So I'm not sure whether or not this is something we'll be focusing the same on as we go into next year, but pharmacy will still be a very important part of what we survey our providers on. Next slide, please. And behavioral health provider results. So again, very high rates with regards to interpreter services and timely access. And again, pharmacy seems to be a challenge there with the behavioral health providers as well. Okay, next question. Next slide, please. I was just telling Susie, I broke my glasses on the way in, so I'm winging it. So if I say something really weird, it's, All right, so here's some stuff that we're really looking at, that we're actually doing now, and some things that will roll out during the course of the year to address provider satisfaction. So provider relations specifically, and I should probably mention my team consists of the field provider relations team, but I also have provider call center, provider network, we have provider communications department, and our delegation oversight team with our IPAs. So there are actually efforts in all those areas. But specific to provider relations, in January, we went ahead and just did a rededication to serving our providers in the field. And so the team is now out there 4 days a week, and the goal is to hit every physician location, primary care physician location, 10 times over the course of the year. So pretty much a monthly engagement. We're adding specialty care providers, OBGYNs, and urgent care providers to the assigned list of regular rounds. So we have a regular touch with our providers in the field. And then we're looking at how we can better support behavioral health as well with our provider relations team. We're also going to be doing some what I call mini surveys. So as we prepare for this summer's survey that goes out, we're going to be kind of looking at doing some mini surveys with our providers to see what their pain points are now, or how are we doing right now, to kind of prepare them not only for answering the question, getting a gauge on where they are, what kind of improvements can we make here as we go into the second quarter, but it's also to get it in their mind that it's coming, and that what are the things that we really need to continue to help them with, or what are the areas they're excited about. So we'll be doing that. Then specific to behavioral health, we've already increased our behavioral health engagement, and some other things that are important to the overall provider experience from their perspective is internally, take a look at our processes. How can we improve contracting, credentialing timelines, and how can we improve communications with our providers while they're going through some of these processes? So we're looking at those things. Provider call center, it's all about how long do they have to wait in the queue. So we're looking at ways to improve the call time when providers call in, and also ongoing training of staff and how to properly communicate with providers, what's the messaging, and those types of things. I got a great team, I got to say. I'm pretty happy with them. Provider communications is very important because we're looking really at how do we communicate with our providers, and more specifically, how do they want us to communicate with them? Do they want email? Do they want blast fax? Do they want information available through the portal? And then what type of information can we be providing them? Frequency in a way that is better digestible for them. Putting a lot of eyes on what it is they need, not so much what we think they need. And then lastly, again, trying to provide a better level of support as it relates to pharmacy for our providers. Better information. I think communications is another big key there. But those are the main areas that we're really hitting as we move forward here in 2023. Next slide. Dun, 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 dun. I can read that. Any questions?
Just one comment. We're glad you're back.
Thank you.
What took you so long?
Yeah, I don't know what took so long, Susie. Thank you very much.
You know, just a couple of contexts. Thanks, Dan, for sharing. That was really great stuff and great work for the team. But there are two things I wanted to point out that I know, Supervisor Spiegel, you heard at the last provider dinner when we were hearing from providers talk about the concerns on getting the follow-up reports from specialists back to the primary care office. You know, with the change that happened in just healthcare back in the, some people call it, I guess, the good old days, some people don't, but back in the days when you used to have a physician that was part of a medical staff at a hospital where they would all connect and gather at the medical staff lounge, usually in the mornings or in the afternoons, that connection between primary care and specialists was a lot tighter. And when the proliferation of hospitalists happened, where the primary care docs now aren't coming into the hospitals anymore, you have more centers that are now physician-owned for outpatient centers and whatnot. You started to see a split on some of that over the years. And I think some of that is really exacerbated here in the IE because of the connectivity issues that we have a challenge on the medical record side. And this is something we've talked about previously on the need to just figure out a way to have greater connection for our providers, especially on the disparate hundreds of different medical records that we have in the IE that we're trying to connect in with. And so I just wanted to point out that that's something that we see as part of a broader solution in the future as we kind of work through some of the various initiatives that we have, whether it's on the medical foundation side, some of the EMR strategy, some of the pieces on Manifest MedX, but that connectivity is going to be key to try to bridge that gap of what it used to be based on the culture of what medicine was actually delivering back in the day. The second part I think that's important to remember is on the pharmacy benefit side. When the state carved that out, you might recall they actually carved that out of the Medi-Cal program. You have to remember that all of those directives that we had from the state now, and any calls that come into us on the Medi-Cal pharmacy benefit side, we just refer back up to Sacramento. We don't have any ability to get in the middle of that except to share with the state, hey, you've got some issues going on. You guys need to fix X, Y, and Z. I've asked the team to actually go back in time and look at the pharmacy scores, for instance, and make sure that we're sending to the state what the pharmacy scores are for provider satisfaction, because I can pretty much guarantee you, and Susie, you can correct me if I get this wrong, or Takashi, you might know under pharmacy, that the state's probably not doing a provider satisfaction survey on pharmacy, I'm guessing, from the state directly to providers. I don't think they are, that I know of.
I don't think they are either.
We're happy to share that data with them from ours, and they can see kind of what some of that change has taken place because of those decisions that took place there. So I just want to make sure to contextualize a little bit of some of the nuance there in the study of just how things have changed within medicine.
It goes to the fact that Sacramento's taken away local control and how much better at local control we do. So the one thing I do want to say is that we talk about the challenges in the medical field and the changes. I think it's in every field.
Yeah.
But the problem is medical field has a little more focus of literally health and life death. And so that's why we have to be a little more due diligence on this. And I think the surveys, even though we're not happy with every one of them, certainly tell the story. And the lowest seem to keep going back to that pharmacy. overall. So it says pretty much that within the arena, we're doing a pretty good job. Always can be better. We always can, and we can make less mistakes.
Yeah, the team is doing a great job, and big thanks to Susie and Dan and that whole team for the work they're doing. Great work.
Any comments from my colleagues?
No, just, it'd be nice, like you said, to know if the state ever responds back to what it is that you send to them. You know, is that increasing their concern? Do they love the opportunity to kind of reflect on this, or what? Does it go into a deep black hole, or?
Yeah, we actually have a log in the pharmacy that they keep track of all of the issues that we send up to them, and we should probably bring that to you just so you could at least see it and see what either their response has been or the black hole syndrome that might exist as well. So it's a great point.
Yeah, it's concerning. Thank you.
All right, Dr. Ed Junn's got a great quality update for you folks to share.
Great. Well, as Jania kind of comes up to the stage, I just want to kind of share, Jania will be giving an overview of some of the work our quality team has done on specific quality measures. The reason this is important, just as a reminder, is that the Department of Healthcare Services holds all managed care plans in California accountable on a large number of quality measures, specifically making sure that we are either above the 50th percentile nationally or below them, and their preference would be that we are all above those 50th percentile national benchmarks. And in 2021, IHP was, out of 15 measures, above the 50th percentile nationally on 9 of them, and below the 50th percentile nationally on 6 of them. So today, Jania is going to walk the board through what we're doing to improve on those 6 measures, specifically our performance in 2021, and what we're doing from a member, provider, and data strategy so that we get towards the improvement that we need to see. So Jania, I'll hand it over to you.
Great. Thank you, Ed. Good morning, members of the board. Thank you for having us. If you can go to the next slide, please. As Dr. Junn just mentioned, this is a bit of a repeat. We did present this information to you earlier when we shared our latest quality report. But again, the Department of Healthcare Services has really gotten serious around very specific measures where they're expecting plans to perform at that 90th percentile performance. And this report here to the board this morning is really an update to their process. This is something new that the state is starting to enforce for those measures where plans fell below the minimum performance level. Again, this is measurement year 2022. I'm sorry, measurement year 2021. Next slide. This slide summarizes the measures that were held to that minimum performance level. The measures on the right with the green were measures that we met the performance standard, and the measures on the left in red are the ones where we fell below. And so what you can see here, there were 6 measures that fell below the performance level. You'll notice the domain column, we actually, the domain is important because 4 of our measures fell in the children's health domain. And because of that, because we had 4 measures that fell below the performance level in the children's health domain, that's what triggered the requirement to do this SWOT analysis that I'm going to be sharing with you this morning. You also notice that we had some children's health measures in the green box. So we do have some successes, but there are some challenges, and that's actually where we're going to focus this morning, is on those children health measures that fell below the performance level in 2021. Next slide. So the SWOT, it's an acronym that we turned into a word. It's a strength, weakness, opportunity, threat analysis that the Department of Healthcare Services requires all plans to conduct if they fall into this performance level. And so again, our focus here is on the children's health domain measures only that fell below the performance level. Next slide. And so these are the 4 measures, and I just want to point out that after we prepared the packet, we recognize that there's a lot of acronyms on this particular slide, and so you'll notice this morning we printed out a reference sheet for you in case it's helpful.
It's really gives you the definition of some of those antigens or those immunizations that we're referring to. But these are the 4 measures. They're focusing really, 3 of the 4 are focused in early childhood, so from birth through 2 years of age. And so you'll see that we have on our first measure, it's well child visits in the first 15 months of life, where we're looking to get 6 visits done in that period. There's also the well child visits for ages 15 to 30 months of life, where we're looking for 2 additional visits. And then we move into the immunization measures. We're looking for full vaccinations by age 2. And that long list of alphabets are all of the vaccines that our infants are expected to receive by age 2. And then our adolescents are also expected to receive 3 different vaccines by age 13. So this is the focus of our SWOT. Next slide. So some of the work we did in the quality department is really did an assessment of our strengths, weaknesses, opportunities, and threats in these 4 measures. And you'll see the full listing here. We have quite a few strengths, things like provider incentive programs, member rosters, good data exchange. But we also have some weaknesses. Some include our mom and baby link, linking the mom and the baby, because in that first couple of months of life, care may be provided under the mom's benefit, and that information may not actually connect back to the plan easily. We also found some opportunities, things like leveraging sick visits. While patients may not be coming in for their WellCare visits, they may be coming in for sick visits, and so are there opportunities where we can act in those moments? Another column there is the threats, and so things like delayed vaccines that occurred as part of the pandemic, and vaccine hesitancy are also some of the things that we noticed in the kind of what's happening under the hood in some of these measures. Next slide. So using that SWOT analysis, we identified 3 areas that we were going to focus on in the next coming months, focusing in 3 areas, starting with member engagement. We want to increase our member engagement through enhanced communication methods, and we also want to be intentional about assessing the effectiveness of those efforts. For strategy number 2, we're going to continue to work on improving provider information exchange. While we had some strengths, we also found some opportunities, so we want to continue to work on that. And number 3 is working on coordinating care for that newborn, ensuring that they get what they need right after delivery, and how can we make sure data exchange is working the way it needs to. So those are the 3 areas that we were focusing in. Next slide. And so kind of getting a little bit more detailed for the first strategy of member engagement, we're really looking at improving by creating a new health scorecard for our members. And we're also looking at assessing our current member incentive program. We do have incentives, and we actually find that is a strength, but there may be some opportunities to improve our operational kind of workflows and timeliness of the distribution. So those are the 2 action items under member engagement. Next slide. Under provider information exchange, one of the things we're looking at is deploying a new resource at IHP called the Quality Engagement Specialist, which is part of our new quality regional model approach, where we're going to be really deploying staff into provider offices to help really support some of those specific quality measures and doing member outreach and support. And then the second item on provider information exchange is new enhanced provider-facing reports on our provider portal. Next slide. The last strategy, newborn care coordination. We're partnering with One Network Hospital as a pilot with an intention to spread in partnership with our hospital relations team, looking to facilitate a process to coordinate care post-delivery. And so we're really looking to see ways that we can actually partner better with our hospitals and our IHP care teams to support mom in getting those enrollment packets and getting baby connected to primary care services right away. On action item 2, we're also looking at the data gaps, specifically focusing on the hepatitis B that's typically administered at birth in the hospital. That is actually one of the areas that we're finding the gap. And I believe, if you go to the next slide, this is just kind of a progress on where we're at. This is, again, the state timeline. They require that we kind of keep a progress report, and we'll be providing them an update in May and again in September. But we've completed the first 2 steps in November and January. So this is just a high-level time frame. And next slide. That is it. Any questions?
Just, I mean, it's a theme here. I mean, we're offering all this stuff. It's really trying to get the member to, A, keep their information accurate in our system, and then doing the things, and I'm just as bad at doing all the things you're supposed to be doing at certain age groups and certain things, whatever test. Anything out of the ordinary you see in any of the plans, like incentivizing the carrots, what do we do to get these guys to actually do these steps? Because we're getting graded on it.
No, absolutely, great question. And there's a lot of collaboration happening across the plans. The local health plans of California quality directors get together on a monthly basis to talk about some of the best practices that we're doing together, to share. Supervisor Hagman, one of the strategies that we're approaching is reassessing and kind of revamping our incentive program for our members based off of some of the learnings from other plans of, is there ways to get those gift cards in the hands of our members right away to make it a little bit more meaningful and tangible versus through mail with a delayed response. So we are looking at kind of feedback on what's working from in other places, as well as the design challenge
I mean,
that
I'd be
Dr.
just
Judd
curious to
mentioned.
see what, we have all this extra dollars, but we spend it in a lot of indirect ways. Is there a way to, hey, if you do this, you're going to get a $100 gift certificate for diapers because you're doing through all the proper things? I mean, is there some, I don't know what the rules are, gift of public funds, or I don't know if it's considered the same thing or not, but, or if we don't give them the actual gift card, but we physically give them diapers and baby stuff and whatever we do, if you complete these steps, you know, is there incentives we could do that more direct to the person versus just hiring more and more marketing and things like that? I'm just wondering, what is our restrictions? What can we do?
Yeah, maybe I can add to that. So one of the things that we did as a quality team was to first kind of assess, you know, what the problem is in terms of impacting our ability to improve. And one of the ways we did that was we looked at national best practices, local best practices, and wanted to compare that to what we were doing. And one of the big things that we found is that there's some contextual nuances and differences between what we here in the Inland Empire have to address versus some of the other 5-star plans, for example, in areas that might have smaller geography or more control over their network. And once we identified that those were some of the nuances, the next step that we're taking now is to better identify how we can either be more creative or address things that help us move the needle. So I think in terms of understanding what's out there and what other plans are doing, we have a great inventory of that. Where we are at right now is finding a way to contextualize and adapt that to sort of how our network is structured, how our members are distributed across, you know, the regions and what our providers are and are not capable of doing yet. So I think you'll kind of see a little bit more of a shift and more of a targeted approach that works.
One quickie question, Madam Chair. How much of a challenge is the documentation piece of all of this versus some of the other coordination gaps and all?
Significant documentation challenges around the data capture, especially services like, you know, all of the different vaccines that need to be administered in that first 2 years of life, as an example. That is some of what we learned in the root cause, is that there are certain places where gaps exist, especially with that mom and baby connection and services that may have been delivered to the child before they were enrolled with the plan. So those are some of the significant sort of data issues that we're working through. And there are a lot of activities behind the scenes that we're working on to close that gap.
So as we improve our ability to capture information, hopefully over time, to digitize these things, that should also give us a boost potentially.
Absolutely. And a big strategy is the Health Information Exchange and our California Immunization Registry connections are two big ones, just from a infrastructure perspective. If everyone can get
That makes
documentation in a central place, it doesn't matter where members go, everyone can see that record.
Maybe just to give that context again, we have over 500 directly contracted PCPs on over 120 different EMRs. So if you look at some of the opportunities that lay ahead of us, this data capture consolidation is definitely one of those areas that might help us kind of get that boost that we need.
Thanks.
Thank you.
Yeah, just want to say a big thanks to Jania and Ed and actually the entire team. This is another one of those areas, similarly to what we talked about with redeterminations, where everybody is giving all kinds of ideas and feedback and insight, and we welcome that because we think, to your point, Supervisor Hagman, we have to just be thinking differently in the approach. It's very unique here in the Inland Empire, to Ed's point, on how things are connected, and so any ideas that you folks have on these kinds of initiatives for us, we absolutely welcome. So thank you for sharing.
Okay. So, Section 10, IEHP Health Access, we have no business. We are now at comments from the public on matters not on the agenda. Do we have any comments?
No, ma'am.
Okay, we are now at board member comments. I just want to say that I hope everybody, Jared opened up about this weekend. This was it is just an unusual weekend. It was a celebration by three major faiths of Ramadan, which began and ends on April 20th. Passover began, and so we had Passover, and of course Easter. So on Sunday, you had Ramadan, Easter, and Passover, the crossover of the three big faiths here in the world. So it was a very interesting time, and I had the opportunity to dip my hands into all three. So it was a very good weekend, so I hope everybody else took that opportunity to reach out to somebody who's of different faith, or if you are no foundation, that you've found somebody who had a foundation and learned a little bit. So to me, education is one of the most important things that brings us together. So with that, there are no reportable actions as we're in a closed session, so we will now adjourn the meeting till Monday, May 8th at the Inland Empire Health Plan.